Welcome back to Breathe Easy. We're now on episode 35 and we're continuing our ICU Liberation series. Today we're tackling E, early mobility and exercise. Think of early mobility as an ICU team huddle in motion. Everyone has a role and the respiratory therapist keeps the airway and breathing support safe and steady. We assess pulmonary readiness, protect the airways, support ventilation, and help the team move the patient safely from bed rest towards recovery. Let's get moving. Here's one of our patients, awake, following commands, mechanically ventilated, and stable on moderate support. PT asks whether the patient can sit on the edge of the bed. What do you need to know before saying yes? Think beyond oxygen saturation. We need the airway, ventilator support, work of breathing, recent trends, secretion burden, hemodynamics and alertness, lines, and enough trained hands. The answer is not automatically yes or no. The answer is let's assess and make a plan together. Early mobility does not always mean walking down the hallway. Think of it as a ladder. Range of motion, chair position, edge of bed, standing, transferring, then marching or walking. Or when is the safest, meaningful step for today? A patient who sits upright for 5 minutes may be making major progress. The key is to set a daily goal and avoid waiting for extubation before we even start thinking about movement. Before movement, use 4 buckets. Airway, support, patient, and plan. Confirm the tube, interface, or trach position and securement. Create enough circuit slack without creating a jungle. And review mode, oxygen, PEEP, synchrony, work of breathing, recent desaturation, and secretion. Then assign roles. Who owns the airway? Who's going to be managing the ventilator? Who handles the lines? And who leads the movement? If everyone thinks someone else has the tube, that's not a plan, it's kind of a plot twist. During activity, use the 4-watch rule. Watch the patient, airway, ventilator, and lines. Look at the respiratory pattern and work of breathing, not just saturation. Watch the circuit for any tension, review delivered tidal volumes for sudden change, and waveforms for flow starvation or asynchrony. Listen to what the patient's telling you, verbally and non-verbally. The monitor is part of the assessment. It's not the entire assessment. A simple way to frame tolerance is green, yellow, and red. Green means the patient's stable and progressing. Yellow means modify, slow down, rest, or adjust positioning, clear secretions, or provide appropriate respiratory support with orders or protocol. And red means stop and stabilize the patient, especially with persistent desaturation, acute distress, any types of airway concern, or hemodynamic instability. Use your organization's policy for thresholds, and the goal is not to prove the patient can tough it out. The goal is safe progression. Time for a myth check. If a patient needs a planned temporary increase in support during activity, the attempt did not automatically fail. Mobility increases demand. Our job is to anticipate that demand, assess synchrony, and support safe participation with our orders, protocols, and scope. Then reassess and return toward baseline when appropriate. In other words, mobility is activity. It should not become an accidental, spontaneous breathing trial with a walking patient. When the movement ends, our work is not finished. Reevaluate your patient. Make sure their circuit connections and airway position is appropriate. Return temporary changes towards the baseline when clinically appropriate, and then communicate what happened, the highest level achieved, the respiratory support used, and any barriers, and what you would recommend next time. Document the progress, not only the problem. Today's edge of bed session gives tomorrow's team a starting point. Here's the whole episode in 5 words. Assess, prepare, support, and monitor, and then progress. Early mobility is a team intervention, and respiratory therapy brings essential expertise in pulmonary assessment, airway protection, ventilator management, and response to intolerance. The ventilator is not a bed rest order. Our goal is to help each patient take the safest next step. Thanks for listening to Breathe Easy. Keep breathing, keep learning, and keep moving.